Hey everyone, Puneet here. Welcome back to the North of Patient podcast, Conversations on Health Beyond Care. This week's guest is Susannah Fox, author of Rebel Health. Susannah brings a wealth of experience from her time as Chief Technology Officer for the U.S. Department of Health and Human Services, where she led innovative projects in open data and technology. She's also served as an entrepreneur in residence at the Robert Wood Johnson Foundation and directed the health portfolio at the Pew Research Center's Internet Project. Her career is a remarkable example of how anthropology, technology, and a drive for democratizing health data can converge to create lasting impact. In this episode, Susannah shares stories from her career, illustrating how patient-led innovations often emerge from the margins. We delve into the patient-led, caregiver-led, and survivor-led movements that are reshaping the healthcare landscape. We also explore the transformative power of peer support and the ways in which empowered patients are bridging the gaps in the traditional healthcare system themselves. The conversation also touches on her book, Rebel Health, which is filled with practical examples and insights for healthcare providers, policymakers, and anyone interested in how grassroots movements can drive systematic transformation. Susannah's perspective is a fresh reminder that the most important breakthroughs in healthcare often start at the bedside and spread through networks of dedicated individuals. So settle in for a thought-provoking discussion with one of the foremost voices in patient-centered innovation. The links to the full conversation are in the comments below. North of Patient is on Spotify, Apple Podcasts, YouTube, and Substack. Don't forget to subscribe on Substack and follow along. As always, I welcome your comments and ideas, plus suggestions for future guests. Without further ado, here's episode 14 with Susannah Fox. Susannah, welcome to the show. So excited that you're taking the time and the opportunity to come here and talk about your very storied career and obviously the wonderful work of your recent book, Rebel Health. Welcome to North of Patient.
Thanks for having me.
Maybe it makes sense to start right at the top. I'd love for the opportunity to learn a little bit more about your career journey and what eventually led you to do the interesting work that you've been doing.
I always like to say that people tell a good story in retrospect. And it looks like I meant to do a lot of things that actually were just good luck or by chance. And I'll start by saying that I am the daughter of an engineer and a journalist. And my dad, who was the engineer, was able to convince my older brother and sister to become engineers. And then I went off and became an anthropologist. And I don't think dad ever really believed that I would have a full-time job. He wasn't really sure. He was so convinced that having a technical background was the right path into life. And he therefore was very surprised when I was the child that ended up being the chief technology officer for the US Department of Health and Human Services. Turns out I was paying attention when he
Yeah.
was, for example, wiring our home. We had a home network. Like back in the 1980s, we were
Mhm.
using the internet at home, and so I am very much a child of my parents. My mom's a writer, and my dad wrote code, and that has to be part of my story. Um, the other lucky chance was in the 90s when I was in my 20s and just coming into the professional world. Knowing how to code HTML was like having a superpower. And to anyone
Mhm.
listening who's at a crossroads in their career or just starting out, always look for those moments when there's a generational technology shift. And I see that with artificial intelligence. HTML in the 90s is like Gen AI today. It
Mm.
seemed like magic to everyone who didn't understand how to put up a website. And figuring that out was what launched me into the work that I'm doing today in a lot of ways.
It's fascinating, and I have to say that that analogy of your mother was a writer and your father was writing code, that's incredibly poetic, and it is really interesting how these things kind of weave together, and life gives that opportunity to sort of piece that journey together. And I know you mentioned that in retrospect it's always more beautiful, but it's also interesting to see how in going through our careers and our journeys. we're often finding ourselves through that as well, right? Even though sometimes it seems like serendipitous circumstances. Maybe when you were young, you weren't able to put into words, "I'm going to grow up to be the chief technology officer for the Department of Health and Human Services." But there you go.
Yeah, and sometimes I tell people I never could describe what I wanted to do with my life, and it turns out that's because it wasn't invented yet.
Yeah.
And being someone who is curious about other people, anthropology was the right training. It's frankly, it's training for how to be professionally and politely curious about other people.
Mhm.
And I was able to use that training to go into online patient communities, communities of people living with rare and life changing diagnoses, and learning from them about how they were using technology was again like a passport to the future. And because people who are hard hit by life often are creating the tools that they need, inventing what they need. And if you just follow them, you'll see the future faster.
Absolutely. And I'm definitely looking forward to diving deeper into the conversation around generative AI and how it intersects with so many of the themes that you've talked about and that you've worked on, because it is indeed a extraordinarily exciting and unique time right now. But maybe as a starting point, talking a little bit about, I guess, most recently, Rebel Health. Um, can you tell us a little bit about what inspired the book itself, and what would you say the key takeaways would be for healthcare providers and for policymakers that come across this work?
Sure. For 20 years, I've been tracking the what I like to call the patient-led, caregiver-led, survivor-led revolution in medical care, watching what people are doing at the bedside and on the front lines of healthcare among themselves. So people who are left out or ignored by mainstream healthcare often gather together peer to peer and solve problems. So I followed these groups as a researcher, and then as my career progressed, I started getting invited into higher level conversations in healthcare, got invited to work in the Obama administration, was talking with people in corporate boardrooms, people who are investors, people who work in policymaking and foundation circles. And what I found is that a lot of my friends in the what I call the C-suite of healthcare, the CEOs, the CFOs, the people who are the heads of hospitals, often can't believe what I'm talking about when I talk about the innovations that patients and caregivers are creating. And then when I talk to my friends who are part of the Rebel Alliance of Healthcare, the patient innovators.
Love that terminology,
Oh,
by the way,
thank you.
as a Star Wars fan.
Right? What I also noticed is that people in the Rebel Alliance of Healthcare didn't actually know all the time how to express their power and how to show what they are doing is salient to mainstream healthcare. And so I wrote this book as a way to introduce these two groups to each other, to say to people who currently hold power, you need to pay attention to the rebels, and to say to, uh, frankly, regular people, whether or not they're part of the revolution yet or not, anyone who feels left out, anyone who feels that their questions aren't being answered, anyone who is undiagnosed or struggling to get attention for their problem in healthcare, you have the opportunity to become a seeker, a networker, a solver, or a champion, which are the four types of people that you'll meet in the patient led revolution.
Mhm. And I think it is important to also give a vocabulary to these things as you have, for the mere fact that, very similar to what you mentioned, is, not knowing that there was such a thing, or that role not having been invented yet, of chief technology officer, let's say, in the context of Department of Health. I think similarly, if people don't know that there's a space that they can occupy you don't necessarily have that intention, or sometimes you feel like, am I doing a wrong thing because I'm venturing into a space where people as patients shouldn't be going into. So I think giving the terminology as you have in this case, also to a certain extent, it gives people permission to be able to participate. Um,
Yeah. What I also tried to do was tell stories so that people would have pattern recognition, again, on all sides, so that leaders would have pattern recognition for understanding how they could work with patient advocates to get their mission accomplished. I also wanted to create a pattern recognition among people who are currently scared, currently exhausted, currently not sure where to turn in the maze of healthcare, to say, oh, wow, this sounds like something that I could do. And this
mm.
is how I could begin. So, in telling those real life stories of heroes who navigated out of a really tough spot, that's what I also hope to do.
So taking a little bit of a step back in terms of kind of again the inspiration behind the book. Now you obviously mentioned that you're doing research, you're working as an anthropologist prior to a lot of this. Would you say that your passion or again the inspiration to explore this further came from more from a specific personal experience growing up or in your life, or more from actually the research and observing what was happening, or was it a combination of both?
I would say the through line for my career has been a focus on the democratization of data, information, and tools. When I was building websites, I this was in the 90s before I became interested in healthcare. I was very interested in how the internet was breaking open uh, libraries, breaking open stores of data, and giving people access to these tools that could help them make more informed decisions. And then, as a researcher, I started looking at how technology was changing health and healthcare in the US. And it was like, uh, you know, discovering the white whale of Moby
Yeah.
Dick was off the bow of the boat. That was one of the biggest information challenges, in that there was such an imbalance of power and an imbalance of access to information and data, which was certainly true pre-internet. The best information was literally locked up and kept out of reach from patients. It was locked up in medical journals, in medical libraries. People weren't allowed access to their own medical records. People weren't allowed access to the data that was being generated by their own bodies and tracked and recorded by medical devices.
Mhm.
And I became obsessed with watching how people were either choosing to democratize data and information. And we can talk about, there's been some awesome uh, federal government initiatives. There's been some awesome corporate initiatives to do that. But a lot of the movement that I saw happened because patients and survivors and caregivers were demanding that access.
Yeah, and as a really interesting kind of tie into my own personal career as well, everything you're saying is resonating with me deeply. And obviously, I trained as a family physician, and the first 10 years of actually my clinical career, I was working to build a next generation electronic health record company. Here in Canada, it was called Input Health, and our main product was actually something called a collaborative health record. So we were through the name, trying to collaborate with patients and really make it a patient-centered health record. So, what if we flipped the script and we had the patient actually be, an active user of their own record and an active writer of their own record as well? How would that transform the decisions that are being made? How would that transform efficiency that could come downstream if you had them not be external to to the system, right? So I think that very much resonates um, with the early parts of that journey. And an interesting thing, I have to note is um, the extent to which I think the infrastructure of the health system, doesn't lend itself to that type of a notion or that type of a challenge to, I guess the orthodoxy, if you will. Um, uh, we experienced a lot of inertia against the idea that here's 1,000 reasons why people shouldn't have access to their information, and how everything will fall apart if that was to happen, because there'll just be incorrect information left, right, and center, and people will just worry themselves sick. Can you speak a little bit about your experiences seeing a little bit of that, and also where does that stem from? Because obviously people in healthcare are, I would say, by far and large, maybe I'm being a bit of an optimist here, but are well intentioned. They don't mean to withhold or to cause harm. So where does this stem from?
Such a great question. I feel very lucky that I began my journey, my study of healthcare at the level of the patient. And I need to give credit to one of my mentors, Tom Ferguson, who advised me to spend time in online patient communities. When I was tasked with looking at the intersection of healthcare and technology and writing survey questions about it to try and track the social impact, he said, if you want to see the future, hang out with people living with rare and life changing diagnoses. And that allowed me for the first decade of my journey into healthcare to spend time with those rebels, so that then when I started having a better understanding of the challenges at the corporate level, challenges at the level of the federal government, I could see that there's often a lot of support at the grassroots or at the front lines, or if you're talking about at a hospital, there would be support for change among the nursing staff. Or speaking at the federal government level, you could see, for example, in food inspection, which is a big part of one division of what we do at the FDA. The food inspectors would want to see change. Um, and maybe the CEO of the hospital or the head of a federal agency, who frankly, they get paid to be visionaries. They get paid to see the possibility of innovation. So you'll have these two layers, the grassroots frontline layer of the patients, the nurses, the food inspectors, and then you'll have the CEO, the leadership. Um, they'll be on board with change and innovation. What you really have to watch out for, what I've learned, is what I call the permafrost of middle management. The
Mm,
permafrost of middle management is not asked, they are not rewarded for being out of the box thinkers. They're rewarded for making their quarterly numbers.
yeah, yeah,
They're
that's
rewarded
true
for
in public
keeping the
corporations
trains
as
running
well.
on time. Exactly. And
Yeah.
so any innovation, and that is very true in government, and it is very true in healthcare. And that's one of the lessons that I learned, running an innovation lab, which was the role of the chief technology officer, was to run an innovation and open data lab. You had to find a path through middle management. You had to show people that there's two ways to get a change through that kind of situation. One way is to pitch it as, this is very much like what we've always been doing, but a slight change that's going to make it better.
Mhm,
It's a
mhm.
slight change that's going to make it more efficient or more cost effective. And you need
Yeah.
to appeal to that person that you're trying to convince. Um, but when you're trying to convince the CEO or the secretary of a department, of an agency, you want to say, this is completely different from everything that we've ever done.
Yeah. So you're changing how the ROI is communicated there.
Yeah. But it's
Yeah.
really, really challenging. And one thing that we have to acknowledge in healthcare is that we have to be careful. Lives are at stake.
Yeah.
And we have to innovate. Lives are at stake.
Yep. Yep. No, that's a fantastic way to put it. And I think you're absolutely right. I think knowing the audience and being sensitive to their realities and their mandate, which is of course different depending on where you are in the system, right? And in many ways, in the case of especially kind of people in the front line or people kind of stuck kind of in the middle of care delivery, it is a little bit of reducing anxiety. Things are hard enough as it is. Are you throwing in a wrench into this machine that's barely moving and that's just going to throw it all apart? Or are you actually, or are things still going to continue to work? So that's a great way to frame it. Um, so I guess going further into that, so I guess first of all, the even just the sound of being involved in that kind of a role in terms of being a chief technology officer of such a large portfolio. What would you say? I'm sure you touched on many things, but what would you say you were most proud of in terms of your accomplishments?
Well, I was the third of three CTOs in the Obama administration, and I served for the last 2 years of the second term. And in that role, I was picking up a portfolio that had been created by Todd Park and Brian Civic. And I didn't, frankly, have a lot of time. I was able to create one initiative about the hardware of healthcare and how the maker movement is this incredible opportunity to learn from people about the assistive and medical devices that they're inventing. But for the most part, this was a well-run train. The Open Data and Innovation Lab that I stepped into was already a really full portfolio. But what I noticed about a year into my job and about 9 months before my job ended, before we knew who would win the election, you begin transition plans. And
Mm,
what I noticed is that while we had this incredible, wide ranging, well worked out portfolio, we were running prize competitions. We had a startup accelerator that was for people within HHS, federal workers to think like a startup company. We had a ventures fund for high potential, high reward initiatives that were coming out of our accelerator. Um, we had so many programs that were so successful, but there was no documentation for how these programs were run, so that if we were snatched by aliens, nobody could replicate how these programs were created and run. And so, one of the things that I am most proud of is that I asked the team to document how did you create this program? How was it run? So that they could continue past the Obama administration. And that's one of the really important things about innovation. It's really fun to create something new, and it can be kind of boring to document the code and document how you did it so that it can continue. And that's the hard work that I asked the team to do as we were getting ready for transition. And then what I'm also really proud of is I brought in an expert on how, when startups get acquired by a big company, how do they survive? How do the executives of the startup survive acquisition? And I brought in somebody as a coach for a 2-day session to teach my team, who are all federal workers who were going to stay no matter who won the election, to teach them how to pitch themselves to the new secretary. Um, so to basically pretend that their startups being acquired by a big company, and it might even be a hostile takeover. um, and then The third accomplishment was handing the portfolio to the incoming CTO, Bruce Greenstein, who was the first CTO in the first Trump administration. And I'm very proud to say that he picked up the portfolio and ran with it, expanded it in some wonderful ways, and the program continued, um, which is what we want to see. When something is good, it doesn't matter that it was started by Democrats or started by Republicans. If something is good and it serves the American people, then it should continue. And that's what I'm
Yeah.
really, really proud of.
Yeah, that's fascinating. Lots of really interesting points to unpack there, and because one of the challenges I've experienced as well. Again, my company was acquired, and we very
I
much
saw a
experienced.
flicker. Like when I said
Yeah.
acquisition, I was like, okay, I want to hear the story.
So yeah, I won't go into too many details, as many of these things weren't too long ago, but I think there are challenges coming into a much larger organization that which has a different culture and a certain movement, and there's obviously 10x larger or more 10x larger team. It's extremely challenging to do that. And we did that in the middle of the pandemic. So, we had team members that we'd never seen and met in person before who we're now working with every day. And whose ideas, in many ways are challenging ours and vice versa. So I think that transition is hugely important. One of the things I was going to double click on there is that idea of how do you keep um, the incentives sort of aligned when, and regardless if it's a startup or if it's a big corporation or if it's a government agency, there's cycles to everything, right? Founders have cycles and their incentives change over time. Investors have certain cycles, and as a result, their behavior and their desire for where the idea needs to go has an expiry date. And same thing with government administrations. What do you think are the things that allows a handover like that continue to mean something, especially when often there's incentives to build something new or to have something you can put a stamp on, or say something's like a political success?
Well, I think that we had a few things going for us in that the office of the CTO had been very successful in a way that was appealing across party lines. And entrepreneurship is, for as an example, is appealing across party lines. The open data initiative, making sure that all of the healthcare agencies data, instead of publishing it as PDFs, which was seriously, it sounds like a ghost story, but the government used to publish all government healthcare data as PDFs. And the Obama administration said, that's going to end. We're going to publish this in a way that people can actually use the data, whether it's from NIH, FDA, CMS, any of the healthcare agencies. And I don't care whether you're a Democrat or Republican, that's just a good idea. And so there were some aspects to our portfolio that are so good that they were taken up. Whether it was a Democrat or Republican in the seat. And we have seen that historically also at the Office of the National Coordinator for Health IT. That also, and that is the part of HHS that has led the charge for the spread of electronic medical records.
Mhm.
And again, it if you look at the history of that, you see a similar history as we saw in the office of the CTO, that no matter which party is in power, this is just on its face a good idea.
Yeah.
And but here's the key: how do you know it's a good idea?
Mhm.
And that is there are metrics. So, something that we also did before the close of the Obama administration was create a kind of a yearbook where we gathered together all of the ways that we could measure our success in these different projects and across the portfolio, because that is very important. You can't just say that this is a useful, successful program. It's
Mhm.
great to be able to show it with numbers.
Mhm. Yeah, no, and I I think that's hugely important. To me, the challenge often becomes what are those metrics and is there overlap in the metrics? And one of the things as an outsider to the U.S. health system, obviously the complexity of the U.S. health system is something that's obviously a pervasive concept that's well understood. But one of the things I often hear is that different segments of the healthcare system have totally different metrics, right? In terms of what success is. Like insurance companies might be incentivized to not have people on certain medications, whereas frontline providers might be wanting people to be on those medications to achieve outcomes. And how do you, I guess, what is the antidote to that? I know
Yeah, that's
it's a
probably a
complicated topic.
question way above my pay grade.
Yeah.
But I can tell you that what I've observed in terms of how patients make the case to get access to a drug is that they will collect the data. Um, and we see this in particularly since a lot of my field work has been in communities of people living with rare disease and life-changing diagnoses. I've seen it where there might be an existing drug that might have an effect on a rare disease that just hasn't been measured yet. And so
Mhm.
it's up to the rare disease community to gather the data, to create the study themselves, and create the data registry themselves to prove the point. And that's the part of the revolution that I'm very excited about because, again, we have democratized access to information and data. We have democratized access to the tools that allow people to measure. Um, we can now, create instruments to measure effects, and um, people are able to understand how to create this data registry at a level that they can speak to the FDA or speak to a pharmaceutical company and say, we've got the data to show that we as a community should have access to this drug, as an example. And so instead of it only being a conversation among people with letters after their names,
Mhm.
it can be a conversation that includes people with lived experience.
Mhm. Yeah, and that's incredible to see. And it's on one hand, I feel like it's unfortunate that it ends up having to be left to people that have to do that. But at the same time, we also exist fortunately at a time where people have more access to resources and they have a voice today in a way that obviously not too long ago those tools, technologies, and platforms would have never existed. Um, one topic that has often come up when I have conversations around this idea of this patient-led revolution with colleagues in the healthcare system is this idea of patient vulnerability,
Mhm.
and being preyed upon by like pseudoscience and kind of the unfortunate things that come with the quantified patient. I guess what are your thoughts in general about that? About the fact that I could get access to some information coming through some blood work reports. Literature in the traditional healthcare community might not know what to do with that information, but where you do turn to, it ends up being sources where you don't really know, is that believable science? Is that not? Or is this somebody marketing something to me? How do we, what are ways in which we can deal with that?
Thank you for that question because it is the elephant in the room. And uh, it's often talked about in terms of misinformation and disinformation. And just a
Mhm.
quick sidebar: misinformation is a mistake, disinformation is on purpose. Both are incredible threats to society and therefore need a whole of society response. what I have seen in healthy patient groups is that they build up antibodies against misinformation, pseudoscience, disinformation, false prophets,
Mhm.
prophets with a PH,
Yeah, yeah,
often that also are getting real profits with an F,
yeah,
off of their work. Um, but a healthy online patient community will build up antibodies so that if something incorrect or is an exaggeration is posted, people will swarm it, and the white blood cells essentially will swarm it and ask for sources and ask for the fact checking and say, where did you get this information? And even take down something that is very clearly an advertisement or somebody who's come into the community just to try and sell something.
yeah,
And those are the skills that we all need to build up. So there's somewhat of a responsibility on the patient and survivor and caregiver to be your own best fact checker.
yeah,
However, there's also a responsibility for people in power, and that
yeah,
is we need open source publishing.
yeah.
We need everyone to have access to all the science, not only in preprint, which is awesome, but
Mhm.
we need full access to the medical data so that all of us are empowered with the ammunition that we need to say that's wrong, here's the real science.
Mhm. Yeah, and I think that completely makes sense. The other thing that comes to mind is, whether there needs to be a greater emphasis on the education system or integration within the education system, both for people going formally through training, but also in general public education around how do you what are the things to look for that make something reliable? What are the things to look for that are red flags? Um, this should be like public health announcements to a certain effect, to a certain extent.
And media
Um,
literacy, right? Like this is
yeah,
not just a healthcare challenge, this is an everything challenge. And
yeah,
we need to understand, so how do you tell when something's real or not?
yeah,
And that's going to become increasingly difficult.
yeah, completely. And on the other end of the spectrum, there's also, in general, the challenges with science and medical science and trust in medical science. And as somebody who's a physician by background, and I do completely understand where people come from when they kind of say that I don't trust clinicians because I feel like there's conflict of interest because of a variety of factors that are present. In many cases, there's no transparency in terms of those conflicts existing. In many cases, there's a sense that the training or the institutions themselves are too deeply associated with like industry, for example. It's a challenging problem because all these pieces are, the reality is we don't have life-saving medications if we don't have industry, and we don't have science if we don't have an institution that does things in kind of a structured, repeatable way. What are your thoughts in general about kind of the struggles of medical science and science in a time where AI is obviously coming into the mix, and at the same time, people are being empowered to look through those things.
Well, I'll quote my friend e-patient Dave DeBronkart and say, let patients help.
Yeah.
Right now, we are leaving half the team on the bench by not including people with lived and loved experience in formulating questions that are valid for research. There are so many interesting studies about um, what are the questions that patients themselves would like researched. There's a particular one that I can email you. You can put in the show notes about Parkinson's patients, and there's a real disconnect between what Parkinson's researchers are interested in for academic reasons and what Parkinson's patients are focused on for their quality of
Mm,
life. Well, which one should have salience? Which
yeah.
one? I would argue that the patient's preferences,
Mm,
um,
yeah.
and that's something that I think um, we have some great examples now in certain fields of when patients and survivors and caregivers are allowed to have a seat at the table. They will come up with really intriguing ideas that can change the face of treatment. Um, there's one in breast cancer. The National Breast Cancer Coalition was able to recruit people for a clinical trial that resulted in breakthrough research. There's another story that I tell in the book about multiple myeloma patients. There was a patient advocate who sat at the table with the clinician scientists and argued for a um, a, a study to see if they could change dexamethasone dosing, which was the frontline treatment for multiple myeloma. And all the clinician scientists said, "Oh, that's such an old drug. That's so boring. Why would we want to test dex dosing?" And the patient advocate said, "Because it's killing us. It's so difficult to go through this frontline treatment. It's so toxic. Why don't we test to see if we could do lower dosing and see if we can have the same success?" And
Mm,
happily, the rest of the committee listened to the one patient advocate. They did that study. It was a wonderful breakthrough study that showed lower dex dosing could have just as good an effect with higher with lower mortality, so higher chance of someone surviving that first line treatment. And it is now that the resulting paper is the most cited paper in multiple myeloma. So if you
wow.
listen to patients, your paper is going to get cited.
Yeah, you would think it should be that intuitive, but it's hard, right? Because there is that there's still that legacy feeling of the patient not really being part of the team or part of the equation in that sense, right? The system knows best. But no, but that's a really fascinating example. And the thought that comes to mind from a primary care perspective is the shortening of antibiotic doses. So obviously, recently there's been a move towards minimum required antibiotics needed for things like, bacterial sinusitis or even pneumonia. And because we know that, well, even beyond like the unfortunateness of having to take medications, we also know that there's untoward consequences to continuing to be on antibiotics. And one of the things that I feel like is an interesting other element that patients often don't get exposed to is the reality of the extent of how decision making, especially in primary care, lends to the side of what is perceived to be in the best interest of the patient,
Mm.
but not necessarily in the best interest of the patient. And again, antibiotics are the perfect example for that, right? The number of times you kind of hear that, well, it's a lot easier to give people what they want, quote unquote. If they're coming in for antibiotics, give them antibiotics, then have to like get into this combative 15 minutes about why somebody shouldn't be on something. But that's an interesting example of where communication and our existing approach towards how we talk about treatments and how people are informed about them just tends to fall apart because that unfortunately is still pervasive today.
Yeah, I am naturally an optimist. So I really hope that the more people have access to information, the more it becomes easy to consult Dr. Google, the more we can feed that information stream with good science so that people can be educated and say, "You're right. I don't want to put my kid on an antibiotic if it's not warranted because it'll really mess up their microbiome."
Mhm.
Why don't we, anytime somebody Googles an antibiotic, name of an antibiotic, let's like have something right next to it about the microbiome. the,
Yeah,
the more we understand the interplay of these
yeah.
questions, um, and what something I'm super excited about is with generative AI, what if we could have all of published science translated from every language into every language and um, served up to people in ways that fit their learning style. So,
Hmm.
wouldn't it be awesome if there was a cartoon about
Yeah,
antibiotics in the microbiome
yeah,
that would help everybody to understand the trade off, that sometimes we really need to give the antibiotic and sometimes we don't. And this is
yeah,
why it's better sometimes if we don't.
yeah. Yeah, no, and 100%. I think that that personalization of delivery is going to be a really, really interesting thing. And I'd like to circle back to Gen AI in a second. But one question I was going to ask was, you know, in terms of how different generations consume information, and obviously the trend towards, let's say, social media, video, influencer-based knowledge translation being particularly significant in Gen Z, and to an extent millennials as well. How do we reconcile with the challenges that people are just being inundated with just a whole bunch of stuff and trends towards what people consider reputable? Like, if I believe in somebody's politics and they're an influencer, well, then I'm going to believe their decisions on what to do with cancer, what to do with something else, right? You kind of see that happening where, experts in one domain are bleeding into others, or the influencer profit, if you will, ends up garnering a lot of influence on areas where it simply just doesn't seem to make sense. How do we tackle that?
I don't know. That's a question I have to confess I don't have an answer to. I have a hope. My
Mhm,
hope is that as we progress towards a AI created media landscape, that more and more people realize how important it is to connect with fellow humans. And maybe people start to spend more time offline, or if they're online, they're connecting with people they know. And by that I mean online friends are real friends. Um,
mhm,
but my research and my passion centers around this idea that a peer, someone just ahead of you on the same path, can be the educator, can be the counselor, can be the friend that you may never meet in person, but could help you through a decision. I call it the just in time someone like me that
mhm,
you wish you had when you're trying to make a decision. And what I hope is that all of the social media can encourage people to connect one on one with peer patients, survivors, and caregivers. Um,
mhm,
what I like to say to people, and I really believe this is true, I've lived this myself, is that whatever you're going through, there are people who would love to help you if only they knew how to find you.
mhm,
We need to find ways to raise our hand and say we need help,
mhm,
because we do have a loneliness epidemic, as our Surgeon General Vivek Murthy says,
mhm.
and human connection is the antidote to that.
Yeah. Hearing your words, it kind of makes me also think about how, one kind of silver lining in terms of the abundance of AI and AI agents that we'll likely see over the next coming years is that, to a certain extent, it does create a different definition of a global tribe, right? Because
Mm.
ultimately, uh, to a certain extent, it will draw the line of we are all human. And when we have a reflection of an intelligence that's quite clearly not, and maybe some of those other factors and other differences actually get cast aside, and we focus more on what's in the interest of people, as opposed to what's in the interest of subgroups of people. So that could be an interesting factor that sort of brings people together towards a common cause of sorts. Um, But going to the generative AI conversation, there's a theme that I always like to explore with guests, and because I find it's a question I'm fascinated with, um, and it's this idea around what the ideal role of the human healthcare provider will be in the context of an evolving technology that over time is going to become more, diagnostically and clinically intelligent, but likely also socially and empathically intelligent. Um, where do you feel the human fits best, and what's realistic in terms of thinking about humans in the healthcare system?
I would love to see humans still in the loop, but I am an optimist, as I said,
Yeah.
and really believe that Gen AI can can be there as a guide. All of the coaching and guidance that a primary care clinician does can often be, I think, in the future will be done with Gen AI coaches.
Mm.
What can't be done is the physical exam and laying on of hands, the um, looking someone in the eye and calling them on something. I think that maybe that could happen in the future, but I'm just speaking of my own personal experience and what I've seen, that there's
Mm.
something about a human one-on-one relationship
Yeah.
that a human can tell if someone is not telling the whole truth about what's going on at home,
Mm.
or their drinking or smoking or exercise habits. I think that that could be really important. I would love to see human doctors freed from note taking, from interpreting lab results, in making the kinds of decisions that actually a robot could make.
Yeah.
um, I would love to see humans being allowed to be humans more often.
Yeah, no, I resonate with that, and I think it's really interesting because in many ways we at times romanticize the idea of what humans can do in the context of care delivery, and because I think part of the reality is also that humans being humans have different days, and there's days where you're distracted, or there's days where you're upset, there's days where you're at 100% or you're at 50%. But all of that aside, there is still something about being acknowledged by another person who's taking the time to talk to you, even if they're actually not empathic and not on their best, and not really even making eye contact. I still think that the feeling of there having been a person versus, like, let's say, a robot having come in and out of the room who was perfectly empathic, I still think that there's going to be a difference between those two. Because the counter argument that we always get into is that it's not like doctors are always particularly empathic. In fact, everyone has, I think of examples where that doesn't quite translate that way. But there still is something there about that human connection, as you mentioned, that I think going to be an important flicker that we want to maintain. Conversely, on the other side, I'm really excited about the prospects of how just being able to have access to things, to knowledge, and to interactions in a scalable way, where people right now have horrendous situations. And I think about something like, for example, a motor vehicle accident or some traumatic situation, being able to have a 1 hour deeply reflective and empathic encounter with an AI agent at that at within the first 24 hours, and consistently having that, how could that change the trajectory of that individual to somebody not even being able to vocalize or verbalize what's happening. I think it can, in many cases, for all kinds of experiences where people have suffering through what happens in the instant, it could change how that happens. And then the human comes in and validates and builds upon that, and understands what's happened as well. I'm also quite hopeful about just the democratization of at least a certain level of being able to access care to people, so people don't have to wait 8 months to see a social worker or something like that, right?
That's right. There's such a scarcity that
Yeah,
we have to get creative, and we can't limit ourselves with our own experience and our own imaginations.
absolutely. So one question to also think about in the context of listeners and viewers of the podcast, many of whom are healthcare providers in practice or in training or work in the healthcare system. Any thoughts or musings as somebody who's seen the healthcare system from a very different vantage point? What could people in healthcare be doing today to be better prepared for tomorrow?
I would say start now in looking for ways that you can incorporate the patient, survivor, or caregiver perspective into your work. So if you are, let's say, a primary care clinician, or even better, if you're a specialist, but in both cases, I think it's true. You probably know patients in in your practice who are experts in their disease, who are experts in handling whatever it is that they are handling as caregivers, as patients. Think about how you might ask them if they would consider um, writing down their tips about how to live with that condition so that you could learn from them as a clinician. And it will start to open you up, I think, to this idea that you have as much to learn from patients and caregivers in your practice as they have to learn from you.
Absolutely. And I think anyone who's had any type of ongoing relationship with patients and from a longitudinal care perspective certainly realizes that you see the resilience in people, you see the resourcefulness, and I think there's a lot to be learned if people are willing to learn. Um, I'll also say again for listeners, if you haven't read Rebel Health, highly recommend you check it out. It was a fantastic read. Thank you for that. It's not too lengthy of a book, which is nice as well, and it's quite rich with with examples, which actually I really appreciated because a lot of times, even as somebody who's working in healthcare as an innovator and entrepreneur, you don't necessarily think of the entire breadth of different ways in which people are being resourceful or being able to find solutions. So it was eye-opening from that perspective. And yeah, Suzanne, I just want to thank you again for taking the time to come onto this podcast. I really enjoyed our conversation.
My pleasure. It was so fun. And thanks for the shout out about the book's length. I actually designed the book specifically so that it could be read on a long flight or a rainy day. And I did not want to burden people because we are all busy. We are all dealing with a cognitive load, whether you're a caregiver, a patient, or a clinician. So thank you.
My pleasure.